Hello everyone, welcome to our Global Frailty Network monthly webinar. My name is Professor Gustavo Duque. I'm the Kaufman Chair in Geriatric Medicine at McGill University in Montreal, Canada. And it's my pleasure also to be a member of the steering committee of the Global Frailty Network, which is an academic network aimed to the promotion of all aspects of research and academia in frailty, particularly in older persons. And it's also important to highlight that these webinars are organized every month. Once you join the webinars, you will start receiving some information about the Global Frailty Network. So please stay tuned, visit our website, visit our resources, and please become involved in our activities. Talking about the activities, today is my pleasure and my honor to introduce our speaker, Professor Jian Wu. I think that we are extremely privileged that Jen has accepted this invitation. I have known her for a while, and it's great to have the opportunity to introduce her to today. Professor Wu graduated from the University of Cambridge in 1974 after medical posts in the Charing Cross, Hammersmith, at Brompton hospitals in the United Kingdom. She worked in part-time posts in general practice as well as research at the University of Hong Kong. Professor Wu joined the Department of Medicine at the Chinese University of Hong Kong in 1985 as lecturer responsible for the development of the teaching and service in geriatric medicine, becoming head of department in 1993 until 1999, chief of service of the medicine and geriatric unit at Sha Tin Hospital from 1993 to 2012, and chair professor of medicine in 1994. From 2000 to 2006, she was head of the Department of Community and Family Medicine. From 2001 to 2005, director of the newly established School of Public Health, and from August 2013 to 2016, chairman of the Department of Medicine and Therapeutics. She also established the Center for Nutritional Studies in 1997, using a self-financing model to carry out services, education, and research, and the Center for Gerontology and Geriatrics in 1998, offering self-financed courses in gerontology and geriatrics, as well as end-of-life care. Currently, she is the co-director of the COHK Institute of Health, Equity, and director of the Jockey Club Institute of Aging at the Chinese University of Hong Kong, and honorary consultant of the Prince of Wales and Sha Tin Hospital Authority. Professor Wu's research interests include chronic diseases and geriatric syndromes, health services research, nutrition, epidemiology and intervention, quality of life issues at the end of life, and she has an impressive number of more than 900 articles in peer-review index journal. So as I said, it's a real pleasure and an honor. We're going to have Professor Wu's lecture, and then we will be followed by questions and answers. So I invite everyone to use the questions and answer function of the webinar. And with no more preamble, Professor Wu, welcome to our seminar of the Frailty Research Network.
Thank you very much for your kind introduction, Gustavo. Let me share my screen first. I've done a variety of jobs in my career, and I'm kind of reflecting back using those backgrounds to this topic of frailty. As you heard, I started looking after old people, older adults, in 1985. So there was no frailty topic then. So before frailty, what do geriatricians do? They rely on what's called comprehensive geriatric assessment in managing patients. So we had to distinguish ourselves from other specialists because they keep saying, well, what's so special about geriatricians? We look after older people as well. So basically, we said that we have an approach that's holistic, with domains in, physical part, not just focusing on systems and normality, but also function, psychological, cognitive, nutrition, and social. And we assess them, and then we deal with all the domains so that we get a very broad management plan. And all this takes time. And by the time you explain what you do, people have switched off, right? So the question was then, as the population age, there are more and more who would benefit from this ideal model of geriatric care. And there weren't enough geriatricians around. And I think this problem is particularly acute now with population aging in all countries, and doctors really going into interventional specialties rather than geriatricians, geriatric specialty. And then there's this discussion of, particularly in the US, should it be anchored in hospitals, or should it be family medicine in the community? What about nursing homes? Who will look after those people? And so then it all depends on what you do in your country, what your system functioning is. But so when this concept of frailty came along in the 2000s, it was very useful, because basically it can summarize in one word and with definition and a few definitions what sort of patients you think would benefit from geriatric care. And then you can apply the step care approach, where you can screen a lot of people, maybe using automated tools, or people who are just trained to screen, and then they get referred to relevant care. So then your coverage for older people would then increase. So when that concept came along, that was very useful. But then another perspective that was very useful was it highlighted what is happening as you age. So when you practice, you're always wondering, is this pathology or is it age-related change? And how do you distinguish between the two? And essentially, this term frailty covers both aspects. And so in this talk, I'm just going to explore how all the body of knowledge we accumulated since the term was introduced in the past 20 or so years, how it may become from a management, from a doctor's perspective, how to benefit patients in whatever setting they are. And I will mainly use Hong Kong as an example, because I've been working there since 1985, but then I will refer to other studies as well. In particular, I would take reference to the what the UN Decade of Healthy Aging is pushing forward, their recommendations, because governments would listen to them, and many countries have signed up. It's a rather confusing field, but I think we need to understand the different perspectives in order to benefit older people, the health of older people. So let me just start. So these are the big topics I'm going to cover in the 40 minutes or so. Just to recap what frailty is, the underlying pathophysiology, different definitions, clinical applications in different settings. So I think that it's quite useful to have a visual image of what happens to you when you age, so we can hang all these concepts on. And essentially, this is a simplified version of you see a lot of graphs like that from birth to death. And then if you look at function on this side, and this is the dependency threshold. So from birth, you reach peak cognitive and physical function, then you decline, and hopefully you die before you become dependent. And this is ultimately the aim, the goal of healthy aging, that you maintain function for as long as possible. But in reality, what we're dealing with, particularly in hospitals and all health, we're looking after old people, we're messing about with in hospitals. What's happening here? Very negative kind of environment. If you go upstream, if you take the life course approach, really, then you can do more. But the problem with that life course approach is people escape from dealing with people here and here to here, because it's easier and maybe it's cheaper. But in a way, I think we need to do that, and all the things that the broad approach is personal, individual lifestyles, socioeconomic positions, psychological factors certainly affect the individual. But what is more important that we can do something about is the physical environment you live in, and also your social environment. These are very important. And I think the concept of frailty allows people to do more research in this area, how to modify the physical and social environment in order to maintain function. So this is a diagram from Elsa Dent's paper, which kind of take into account this term resilience, right? I mean, in Frailty, let's say you use the free definition, you have 3 states: robust, pre-frail, and frail. And every time you have a stimulus, you have a stressor and recovery, right? And this is where resilience comes in, that the pattern, if you're resilient, you don't fall to such a low trough, and you recover faster. So this kind of takes into account the newer terms that we're using. This is the more clinical one, older term, where you look at disease. So people with a minor urinary tract infection can be pushed from an independent state to a dependent state, whereas people who are not frail won't be pushed into this dependency. So already you're beginning to see 2 strands of thinking. And so in one, it's more like what's happening to the biology of it in terms of diminishing reserve to meet environmental challenges as a result of the aging process. So this is the age-related change part. Whereas the other is more concentrating on predicting adverse health outcomes, use of services, mortality, dependency, disability, and so on. So the last slide taken from Linda Fried's paper. This is a very useful diagram where you can clearly see that the phenotype of frailty, that is the usual 5 features, is underpinned by physiological dysregulation, all the hormonal changes, inflammation, and underpinning that are the cellular changes, many cellular changes, which are the cellular markers, biomarkers of aging. So this is a very neat scheme to relate your phenotype with what's happening underneath in the cell. And so the group did studies to look at, and I just give you one example. If you look at a glucose tolerance test, you can see if they're challenged with glucose, frail people can't cope with the load, and you have this huge rise. And it's like a dose-response relationship. Now, this is very important because when I started working in 1985, a lot of old people had very high post a 2-hour level or 1-hour level, but they had normal fasting glucose. Then the point was, why is that? Are the Chinese different? Are there different Asian criteria for diabetes? And actually, there were some papers that says Asian criteria, we shouldn't use fasting because we should use the 1 hour, 2 hour because it was diabetic level. And that was very strange because the people were perfectly all right. And then now, if you put it in the context of this graph, you begin to wonder, were all these endocrinologists wrong? There's no such thing as a Chinese or Asian level. It kind of makes you think, but I don't want to go into that particularly. Now, this is particularly important with COVID. You see that because of immunosenescence, frail people don't mount such a huge immune response. And of course, they are more prone to influenza. Now, why is that important? Because, again, people ignore all these experiments. So, for example, during the pandemic, there was this obsession with vaccinating older people because they were more at risk, particularly people in OH homes. But nobody looked at their response. I mean, if many years ago I did a study looking at response to influenza vaccine, and people in OH homes respond less. Their carers with a lot of psychological stress living in the community had lower response. And the response don't last so long. So then the question was, okay, fine. The people in OH homes, did they have a high mortality because of their intrinsic frailty? Because only very frail people end up in nursing homes. They have many diseases and there's staff shortage and care is suboptimal. Did they die because of that? Or did they die of, which would make, the infection spread and they die quicker? Or is it because of vaccination? What happens if you vaccinate them? Would you get rid of all this problem? Maybe a bit. I personally, I think it would help a bit, but it's not the only answer if you don't deal with all the other problems. So understanding the biological pinning of frailty would be really very useful in terms of management. So these are some of the questions that I raised that I think we need to ask if there were another pandemic coming along. Now, so this is an interesting graph that the group put out then they looked at the number of systems at abnormal levels. So these are the physiological systems. So, and here then you see that with increasing abnormality, you have the increase of frailty. And which leads me to the other concept, the multiple deficit approach. So this is essentially a mathematical description of things going wrong with you, a bit like if you were a car, and the more things that go wrong with you, then eventually it doesn't work. It doesn't really matter what exactly the abnormality is. So with this concept, you count if it's abnormal, you have a score of 1 or 2, and normal is 0, and then you add up all the numbers, irrespective of what variables you're collecting. And so you have 0 to 1. Most people reach 0.6, and that seems to be a plateau, and then they die. And you see, the attractiveness of this, it'd be more attractive to people in hospitals and so on, because you can collect a whole lot of things with you if you have electronic health records. And so because it's so easy, this concept being used by the general practice system, the UK National Health Service, where they have electronic system, and basically you can program it to produce this figure, and it can guide practice. So when I first came across this concept long time ago. And just then I had a cohort, we had a cohort to 2,000 men and women age 70 and above. And we tested this concept. This is entirely different cohort. It's not Canadians, Chinese, different culture, different ethnicity. And we had collected different variables, albeit it's got social, it's got physical, it's got functional, it's got psychological, cognitive variables. And essentially, the concept holds. You see, we created Frailty index, it increases, you get older, then it leveled off. It's higher in women than men for each age group. And the distribution of this index is wider than that. Women also had less chance of dying at the given time than did men at the same chronological age, and so on. So this was a very interesting perspective. And so you end up with having two kind of concepts developing throughout in the past 10 to 20 years. Then this is more like a prototype phenotype characteristics. And there are the deficit counting, right, if you like. And both have the same kind of outcome if you have the same result, whatever you do, if you're looking at outcomes. But anyway, but the underpinning is two different concepts, because here you can count disease, you can count disability, but not here. Here it's about, so we're articulating age-related changes. And here we're talking about everything, including disease and disability. And since then, you see, in the literature, you have many, many definitions and lots of papers so validating one definition against the other. But the problem is when you apply these epidemiological techniques, what is your gold standard? Unlike hypertension, you know, if you have a screen for, unlike, say, depression, your gold standard is a psychiatrist diagnosis. Here, well, is it appropriate to do this kind of research? So, you know, look at all these scales that we can use, and they all work in different settings, which I can show later on. The difference is that it's the length. Some are very short, anybody can do, some are very long. And it depends on your health system, and depends whether you're doing research or not. And then if you look at the social determinants, so you remember the curve, what about your social environment? When you have a thing like an entity like frailty, you can do research. And so you can see that various things influence frailty. Obviously, your lifestyle, activity, social support, socioeconomic. Men and women, slightly different. So I think it's important to look at men and women differently, because women are more frail, but they live longer. So I think there's fundamentally something different there. And what about the public health perspective? In the public health arena, how do you get it into the system for policymakers? So you can use the Frailty Index. It's easy to understand because it's numerical, to put forward this kind of data that, you know, if a 1.1 increase in Frailty Index, you have a drop in ADL score, and then you can then say, well, you don't want people to be dependent because it costs more, etc., etc. So the evolution of frailty along these pathways, it can build up these data to build up a case for using frailty in practice. And then more recently, there are consensus that says, yes, frailty is an emerging public health priority, listing all the reasons. And this kind of continued advocacy is very important to influence policymakers. you know, some countries, people pick it up faster and they have guidelines and so on. In some countries, it's totally ignore it because it doesn't fit in with the model of things like disease model. And then another perspective that's very important to promoting uptake of this of frailty is very common, particularly in the public health sector. It has to be common before people take notice, right? So if you look at prevalence of frailty using different definitions, it's around more or less around 10%. 10% is not insignificant, but if you add pre-frailty to it, it could be pre-frailty is about 50%. So together, frailty, pre-frailty, 60%, really a big number. So as you can see, this is our Hong Kong data. When we use automatic iPad screening using 5 questions for frailty, we looked at the whole of Hong Kong. I think we had some 10,000 screening data. And this is what might persuade people to take notice. If you look at hypertension, oh, this is age 60 and above. If you look at hypertension, 65%. If you look at the combination of pre-frailty and frailty, is 63%. It's in the same order of magnitude. And if you look at subjective memory complaints, it's even higher. The highest is subjective memory complaints. So you may say, well, is that important? But as a screening question, I think we have to take note, because then they can be subjected to some longer, more detailed screening, and then you may pick up mild neurocognitive disorder, or major ones even. And there had been a study a long time ago that says, ask 2 questions. Do you have any memory complaints? Does it bother you? And this was a study in Germany, and amazingly, this has predictive ability for downstream dementia. So this is the kind of data that might be useful for promoting frailty into clinical practice. And then the other issue is everybody is talking about demographic change. People are getting older. And then a lot of people are still stuck at, well, that's fine. We're doing all right with our healthcare system. But then you have to say, well, no, they're living longer, but they're actually becoming more dependent. So you do studies like saying, well, actually, if you look at birth cohorts, people born in the 30s, look at their frailty index, and they're born later cohorts are more frail. So you can do that using the frailty index, where you have multiple deficits. And you have to collect this data to persuade people, your health policymakers, to pay attention. So this is a Hong Kong database, Department of Health database. So if you look at the trends now, if you make use of this concern about demographic change, papers are coming out in China in disability and frailty in China as well. The Chinese longitudinal healthy cohort study. Basically, you're facing with, you have reduction in mortality, maybe gross disability, but if you look at performance impairments, so this is more the function, you're seeing the opposite picture. So the message is increasing carer burden. People don't die, but they need more care. And similarly, in Hong Kong, we show the same thing. If you look at ADL disability, so specific disability is increasing, and you look at trend in frailty, it's increasing. So public health people take note. Then you have to talk about the concept. So what happens? So what's the big deal if you have frailty? yeah, we know that if they get older, they have more diseases. So a lot of people's mindset is still focused on increasing cancer, heart disease, stroke, etc., etc. But then you have to show, well, even without these diseases, there are consequences. So these are consequences that you can have falls, hospitalization, institutionalization, mortality, equating to increased burden. And you have to emphasize that this is independent of multimorbidity and disability. Because they say, oh yeah, it's just a feature of multimorbidity, frailty. So this is one kind of statistics to show that's quite useful. So these are people falling, and there's a dose-response relationship. Okay, this is using the Frailty classification. And using the same data set, you can plot these dose-response relationship. So this is what makes people stand up and say, well, this is really bad. We need to push people to the blue bar, right? It's quite dramatic. Yeah, I'll use the hospital, specialist outpatient, general outpatient. So this is the primary care equivalent, daycare. And then you can say, well, what about instrumental activities of daily living? So you can plot the same thing, increase risk of all these things. And then you have to put a dollar sign on it. We haven't put a dollar sign on frailty yet, although we did that recently in a group with falls. But this is using old data in Europe with Miguel Izquierdo's group. So you put a cost to it. So what I'm saying is I'm going through all the data that might be useful in improving, in narrowing the research gap between research and practice. So people talk about multimorbidity now, and if you look at dependence frailty, yeah, they do overlap, but we have to focus on this group alone, and then you can plot these graphs saying if you have all three conditions, the risk of whatever, hospital admission, of outpatient attendance, of specialist outpatient are all much higher, to draw attention to frailty as an independent entity. And then what about in the field of different specialties are all developing their own assessment because they use it to predict outcomes, whether they do certain procedures or not. This is just an interesting thing. It's a cross between research and clinical care. If you look at diastolic dysfunction, you get a dose-response relationship between different frailty states. The question is, are we missing a lot of diastolic dysfunction? Or maybe this is a biological manifestation of frailty. You don't get the same as systolic function. And you see, if you look at the components, the three components, fatigue, ambulation, resistance, they're similar to what happens if you've got heart failure, right? And if you just use these components, they predict diastolic dysfunction, but not the other two. Sorry, this is using John Morley's classification. But then the cardiologists can use that, because if you're doing interventional things, you have increased mortality in people who are frail, so you might think twice about the suitability for PCI. And so round about a few years ago, the consensus panel, they're beginning to think, well, what are the recommendations for identification and management of frailty? So they put forward these things: screening, assessment, management plan, physical activity. So all this is a very useful kind of pause and interim assessment of what's happening. But if you go on to the wider thing, the further upstream, there was a slide that where I showed physical and social environment, that slide. Can we manipulate the environment to improve frailty? Because this would impact on your age-friendly city concept. Why that is so important to health. And in a way, it kind of touches on resilience, because you could be frail, but you could be resilient depending on your environment. And it touches on the reserve concept, physical cognitive reserve. And this is a useful kind of framework to talk about, to pin your research on, to make it relevant to practice. So if we look at subjective social status using the MacArthur self-rated 10 ladder thing, you can see that if you rate yourself low, then you have increasing frailty, and this is adjusting for everything, for men and women. And then if you look at where you live, this is Hong Kong data. So this is where you live. We have 18 districts. So obviously you have frailty index, obviously operates through socioeconomic position, operates through lifestyle factors, diet equality, alcohol, smoking, physical activity. But there's an independent path that says where you live would impact independently your frailty status. Whether this is space or air quality, we're not sure. So Hong Kong is not homogeneous. Is that nice places like this and places like that, very crowded. I'm lucky to work in a place like this. And we have places like this. This picture taken in Hong Kong. And so if you look at your green space near your neighborhood, it's associated with less frailty. This is what people can do. And it affects mortality as well. So, you know, there's a gender difference here. So is it direct or physical activity? We don't know. So this is important for urban planning. If you have aging population and you don't want to be flooded with dependent people, think about your urban planning. So let's focus on how we can use this body of knowledge into practice of care of older people. I think we've accumulated in the past 20 or so years that frailty can be put into an equivalent footing to a disease entity, right? It has a definition, it's linked to adverse outcome in terms of importance, has effective interventions that result in improved status. So I think I will show the interventions a bit later. It has a concept, but it's not a laboratory measure. You can't measure it objectively. There is not, and a lot of clinicians turn their nose up at something you cannot measure objectively, even public health people, because they say it's what people think. Right? So I think objective measures will be important. It doesn't have a drug, no pharmaceutical intervention. So all these are issues that if we were to persuade people, we need to understand. Essentially, it's a biopsychosocial model versus single system disorder. So these are some of the points we need to take into account. And in the 2019, there were two papers talking about this gap. This is one of them. It's essentially saying similar things. And the other paper is from Jeremy Walston's group in 2019. And it is basically pointing out there is a gap, what can we do? So you see, it all boils down to what your country is doing, how they view health and social care, what systems they have. So these are I think these are some generic principles we need to align to talk to these people. So this slide shows some of them. And I think whichever country you're in, you need to understand to have a dialogue with the policymakers and the hospital management people. So what the settings you're dealing with are hospital, primary care, preventive screening programs that might be embedded in community social settings. This is the path we're going down. And then you need to use a step care approach because the numbers are so great. And you need to fast, maybe less accurate screening measure followed by more detailed assessment. And then we need to promote age-friendly physical environments. These are all the concepts that the WHO also promoting, particularly the age-friendly environment as a means to improve functional ability. So in Hong Kong, we said, well, the hospitals are flooded with frail elderly people, a lot of dementia. Why don't we do something at accident emergency, have a quick screening, and then refer to geriatricians? We tried that. It took a lot of effort, so we couldn't sustain it. The tools we use are Edmonton Frailty Scale. Why did we use that? Because it looked more respectable to a lot of other clinicians, right? It's SCORE and so on, compared with Linda Fried's 5 points or John Morley's 5, although I think it will make much difference. So this was more, but of course it took more time. It took about 3 times as long. And you need to have a nurse to do it because you can't just train anybody to do it because it costs more. And so, but then we did collect useful data as expected. You see, a lot of people who severe moderate frailty is not your community 10% frail. It's like 60, about half of them. And if you add the pre-frail, the mild, you're more approaching, well, nearly well, the majority of people who present at A&E are frail, and it has huge clinical implications. But how can we screen so many people, assess so many people in greater detail using the comprehensive geriatric assessment? How can we refer so many people to geriatricians? Already the numbers are dropping. So really, this is just a study to show the problem. And we need to devise a way to address that before people can take notice. Because right now they throw up their hands in horror. Well, it's too big. We can't cope with it. But then if you follow that, maybe this would be useful. That if you're frail, you increase your risk of readmission. So managers are always obsessed with readmission statistics. It's part of the performance measure. Total inpatient days, the shorter the better. Mortality, I don't think they care too much about. So that's hospital setting. In the community setting, what are we doing in Hong Kong? We're lucky to have a charitable foundation that supports various projects in elderly. It's one of their themes. So we did a proof of concept project to see what we can do. Right, and this is proof of concept to show that we design a multi-component frailty prevention program in pre-frail people, because that has the highest prevalence, around 50%. So if you tackle that, hopefully you have maximum greater impact. And we showed that it has, you can use this program to reverse your frailty status. So it has also some cognitive benefit to the frontal, some battery we use, because the program consists of group exercise as well as an iPad game, individual iPad game, and also board games. And so using this proof of concept model, maybe we can actually try and follow the WHO recommendation for primary care for older people, using Frailty as a kind of a broad-based screen. We use some survey. We incorporate Frailty into this brief automatic screen with assessment of people who are abnormal, and then ultimately referral to health centers. And so this, maybe we could use this model. So this varies depending on what your country's healthcare system is. So then we, with the same funder, with the proof of concept, we incorporate that into what we call the e-health project. So it involved about 100 health centers in Hong Kong, all over Hong Kong, run by various NGOs. And the good thing about these centers are they develop as a social thing. So they are in your neighborhood, and they try and look after your social needs. But it now has evolved with aging of the population to incorporate a lot of the primary healthcare stuff. So we were able to say, with funding from the funders, to give each center some money to buy iPads or whatever, and we detect these various abnormalities, right? It's very quick. It takes about 10 minutes. And whenever there is a problem, then we train the NGO staff to take some action. So it could be referral, could be running beneficial programs in the center, or could be referring them to, say, mobile dental clinics or whatever. And on the whole, on average, people just screen positive for 3 things. So it's not something that cannot be coped with. So so this is the kind of profile of people. So we cover the whole. This is a map of Hong Kong. So we cover the whole area. This is the kind of thing that we detect, and we reconfirm what we did earlier, what we said earlier. Hypertension, peripheral frail is as common as hypertension. Memory complaints are still the highest, and so on. And then the kind of diseases people always talk about, they only talk about hypertension, diabetes, high cholesterol. They only talk about that in primary care. But what we're saying is, look at this chart, talk about these things as well. And so my colleague worked out some sort of score using this, based on now what the World Health Organization is talking about, intrinsic capacity. So it's multi-domain thing that represent function. Again, these 5 domains. And so she worked out that the higher the score, the higher the likelihood of developing health problems. So this is yet another way where authorities may be hoping to upscale, to create instruments that can show you what the number is. Using the WHO step care approach, you don't need to have nurses. They're higher up in the pyramid. So then we looked at, okay, what are you going to do? So we said that in the centers themselves, they can do a whole lot of these things. They can tackle these domains. But what we found was that the people who need it most join in. This is a usual phenomenon. People who need it most don't join in. So only 20% engage in exercise and cognitive games. And only 19% of the peripheral and frail group engage in exercise and cognitive program. So we have to tackle the sort of behavioral component, and also maybe the staff thinking about that. How do you focus your activities into this group? This is to be expected, because these centers started off by being social in nature. So they say, oh, I'm going to give you these do this program. So yeah, come and join. They have not carried out a targeted approach. So you continue to collect data to convince people. People who've taken part in the games, they improve in memory complaints, just focus on the people who need it. So these are things that you can do incrementally to try and get somewhere with managing frailty in the community. And then, of course, we need to document it. We need to cite it because the policymakers say, what is your evidence? And then if you do systematic review, and when the WHO looks at their recommendations, they look at evidence. And if it's not in the research domain, and if it's not RCT, it's not there. It's a bit difficult, these strategies. So this is to say, well, what about the people who are providing this? What do they think? Do they treasure it? So this is a behavioral thing. If they think it's of value, they think it's meaningful and it increase their membership, they will do it. So this is very important to sustainability of any programs. So if you do an RCT that's successful, it doesn't really help other than getting published, because how are you going to sustain it? So in doing this, you're integrating it into their daily activities, their program, so that they see some of the comments that say that they want to understand old people's needs, the training opportunities that enable elderly, that enable them to get in-house skills and knowledge, because older people turn up and they have to help them. They can't refer them all away. Share resources, work with leisure and culture, good access to navigate the healthcare system, good linkage with the district health centers, GPs, and so on. You develop this network, policies, strategies of support. So maybe some kind of, not a question of just money, but how we can allocate funding, because there is money, it depends on how you allocate it. And then if you're successful in your advocacy and in your statistics to convince people you're doing something preventive, just like checking blood pressure and treating people, then some money will be allocated. So you need to build up all these evidence in order to go somewhere. So this is this eHealth project, some of the lessons we learned. What are the effective programs? How do we intervene with the staff? How do we train them? And this differs in different countries, obviously. And so we are in a position to recommend certain things to the authorities, and also maybe to pitch for continued funding from the charitable foundations. This is government-funded DXC, so we're hoping to, so the whole thing is moving very slowly, but this is the direction we're moving in. So just want to summarize that, yes, we know a lot about frailty in the past 20+ years. We need to, I think most people involved in this field feel that we need to include the concept of frailty into public health and social care policies in all settings. I also point out that different countries need to adopt different strategies. So maybe locally you need to do similar things, or maybe if your government is very enlightened, you can do top-down things. Like in 2017, I went to a conference in Singapore, and the government people were saying we should incorporate frailty into our policy, and all the GPs saying, what's that? And of course, in the NHS, they've incorporated, they have the electronic frailty index in the GP. And there's recently a paper from Scotland that referred these people that they pick up to geriatrician to do comprehensive geriatric assessment, and they were able to reduce A&E accident emergency attendance and also hospital admissions. This is a paper published in Age and Aging in 2023 by Helen Jones' group. So it's developing in different countries in different ways. But I think older people themselves need to understand frailty and be motivated to make lifestyle changes and join frailty prevention programs. Now, how do you do that? And you need to use insights from behavior teams. So basically, you have to make it very accessible. They enjoy doing it. And then when they do it, they feel better. So you don't have to do any score. And in a way, in a proof of concept project, when we started, there are some people who keep on coming. So 5-7 years later, and then you talk to them about why they come. And their reasons are not like my frailty status has improved, obviously. A lot of them said they just feel better. If they don't do it, they don't feel right. So they come 2 or 3 times a week. Now, if you have attained that, you're fine, you've tackled the problem that a lot of RCTs have not done because they're rigorously designed. And when it's finished, end of story. And then some people say, well, they have lots of other reasons, like, oh, they improved their social connection. They talk about that. So this is a social environment support. Maybe they share stories, mutual support. And then some people will say, oh, I lost weight. Well, that is not a good thing, but necessarily. But, people are obsessed about fat. But I think that but how do we promote this program? We promote it by saying it's a frailty prevention program. We have no problem with stigmatization, as in many Western societies. People don't mind this word. So if you were to say, this is promoting your intrinsic capacity program, nobody knows what you're talking about. But if you translate frailty into Chinese, it's something to do with preventing you being old and dependent. So the image is preventing some horrible image. And they absolutely love that. So if you create talks about frailty, they all come. So this is a really very interesting thing about cultural differences between, if you go to, elderly seems like a taboo word these days, and as for frailty, it's just not good. Hence, I think this is why the WHO doesn't talk about frailty now in their promotion of healthy aging. So I think I will stop here. Thank you for your attention.
Thank you very much, Jan, for that fantastic presentation. I think you touched so many different aspects. I invite, we still have time for you want to submit your questions. Jan, we have some questions here. There is a question from Julian Falutz mentioning that frailty as a unitary diagnosis is being increasingly used to withhold otherwise appropriate care, especially in some acute surgical situations. So could you please comment on how to approach or avoid this tendency?
Yes, I agree. It could be used as a two-edged sword. And it's to do with limitation of resources. A classic example is the use of intensive care for intubation for people with COVID-19. I think that there was a lot of ethical debate about that. And how the British handled it was to use the frail approach. In Hong Kong, we just treated everybody. I think you have to be very careful so that people do not use frailty as a tool in resource limitation setting to withdraw care from people who may benefit. I think that this is the danger of guidelines. If you have rigid guidelines, about if you're screened as frail, you cannot go into intensive care or you cannot have surgery, then definitely it's bad. You should not use that. What you need to do is to explain to the patients that if you are frail, you have increased risk of whatever, maybe mortality or and your chance of benefiting from these procedure are lower, and then leave it to the patients. So I don't agree with different specialties or hospitals even using this in the guideline, because once they set guidelines, then you cannot discuss on individual cases. For example, a long time ago in Hong Kong, if you're 65 or you cannot have dialysis. I mean, clearly that is wrong. It's not ethical. But it was in the guideline because they had to limit the service. But then a lot of people make noises. It was ethical debate, and now they don't do that anymore. It's deleted. So I think everybody might go through that kind of stage, but it's up to the geriatrician to defend it.
Well, I think that we are running over time. For those of you who have asked, the presentation will be available online. You can visit our website for the global network on Frailty, and those videos will be available there. So with this, I would like to thank Jan for taking the time to present this fantastic summary of the evidence. I know it's 5 a.m. It was 5 a.m. when you started your lecture, at 5 a.m. in Hong Kong. So it's very much appreciated.
Yeah, thank you.
And for the, no worries. And for those of you who are interested on attending and continue attending our webinars, just a friendly reminder that our next one is on Wednesday, June 14th. Please note that still we are going to have it at 5 p.m. to facilitate the attendance and participation of our colleagues in Australasia. And in this case, we are going to have 3 speakers talking, Professor Ruth Howard, Dr. David Ward, and Dr. Emily Gordon, talking about sex differences in frailty. So I hope that you will join us at our next webinar and that you will invite your colleagues and networks to join this interesting and global initiative on frailty. So with this, thank you very much for joining us, and hope to see you again on June 14th. Have everyone a rest of afternoon, morning, or wherever in the world you are. Have a very nice end of the day. Thank you very much.
Thank you. Bye-bye.